Welcome to today's session. My name is Magali de Castro. I'm the clinical director here at HotDoc, and today's session is a federal budget update 2017, a guide for general practice. So we're going to be talking about some of the key budget measures that are going to be affecting our care that we provide at a GP level, but I'll also be talking about some of the admin considerations. So this is a webinar that we run every year, and it's usually quite popular, which it's a good sign. Obviously, it means that general practice we're quite keen to see how what changes are going to be affecting us, and obviously whenever Canberra decides to make a decision, it'll usually affect us greatly, because obviously Medicare and everything that's attached to it is a big part of the care, of the foundation for the care that we provide. So in today's session, we're going to be talking about some of the key budget items that are affecting our clinical services, so the way that we deliver clinical care. We'll talk about some of the items that affect administrative services, so some of the kind of more admin considerations, but it'll mainly be about clinical things. There weren't really that many exciting things in the admin sphere this year. We'll also be discussing what these budget measures mean for general practice and more broadly for the primary health sector. And we'll also be looking at how this impacts on the work that we do as practice managers, nurses, and GPs. So what did the budget have for us? As we would have already seen in some of the articles that have been released, the very much awaited Medicare rebate freeze is going to see a very slow thawing. So it's a bit of an anticlimax, at least personally, after all this time kind of waiting for this, for the indexation to come back. We're going to have it, but it's going to be phased. So it's actually going to be quite gradual and painfully slow, unfortunately. So the cost of this measure to the government is $1 billion over 4 years. And the way they're going to implement it is they're going to start just with the bulk billing incentives, so our 10990, 10991, I believe, for rural areas. And that's going to be indexed from 1st of July 2017, so this year. But we won't actually see any changes to standard consultation items until next year, July 2018. And then for specialist procedures and allied health services, those will have to wait even an extra year. So we won't see those be indexed until 2019. So it's good news, some would say, but yeah. It'll take a while. Very few clinics are actually going to see a relief in the short term. So we're still going to have to be very clever about the way that we manage financial viability in our practices. But there will be there's a bit of light at the end of the tunnel, which is good news. Another key item is the trial of the healthcare homes. So we know originally the intention was to have 200 clinics starting from July this year. Obviously, that's not going to happen, just in part because the logistics and all the consultation and all of the key ingredients that needed to be put in place didn't quite make it in time. So the trial will actually start rolling out with 20 clinics from 1st of October of 2017, and then the remaining 180 healthcare home practices will commence from the 1st of December 2017. Now, these 200 clinics that were given the grant to be part of what they're calling stage 1 of the rollout, they have been announced and they're listed in the Department of Health website if you're curious to see what clinics got the grants. So as you may be aware, the idea of the healthcare homes, it's really a new way of providing funding for chronic disease management at a general practice level. So what will happen is it'll be a repackaging or redirecting the fee-for-service that we usually provide. So for patients that are enrolled in a healthcare home as a healthcare home patient in a healthcare home practice, we won't be able to claim their GP management plans and team care arrangements. The mere act of enrolling them and putting them into our books, so to speak, will replace the GP management plan and team care arrangements. And so the way it'll be funded is for every patient that we enroll, there's going to be 3 tiers based on complexity. The tier 3, which is for the most complex patients, we as a clinic will be paid $1,795 per year, and that's going to be paid on a monthly basis, and that's paid to the practice, not to any particular GP. Then tier 2 is sort of patients of moderate complexity. That's $1,267 per year. And tier 1, which is the lower complexity patients, is $591 per year. Now, the key thing to remember with this is for these patients, even though we're getting paid this yearly amount on a monthly installments, we're not able to claim any of the chronic disease item numbers from the general practice side. So obviously they still can access their allied health, but we can't claim GP management plans or team care arrangements, any cycle of care items, and even if they're coming in between, like if they're coming in throughout the year for anything related to their chronic condition, then that is expected to be provided as part of their bundle payment. So we can't claim any additional items. The only exception is if they're coming in with an acute issue that is not related to their chronic condition, then in that instance, then those clinics will be able to claim, you know, say other consultations, item 23s, 36s, whatever it is, but only if it's not related to their chronic condition. So obviously this is you know, it's a trial. This is going to be stage 1. From a lot of clinics that I've spoken to, obviously some of the clinics have been successful in getting the Healthcare Homes grant to be part of the first rollout, the first stage, but some of the other clinics that I've spoken to who were in catchment areas that were eligible, they actually made a decision not to apply, because when they did the math for their particular clinics, especially when looking at those patients who would fall under tier 3, they realized that because of the frequency that those patients come into the practices at the moment for care, and this is not necessarily, I'm not talking about bulk billing practices where there might be an incentive to get them to come back more often or anything like that. This is just, you know, a combination, a mix of clinics. When they did the math, they were actually going to be worse off financially. So they made a decision not to go ahead with a Healthcare Homes application. So it's going to be really interesting, obviously, because then we're also going to see, there's been questions about, well, how are they going to police the fact that, you know, you're not going to have rogue clinics claiming standard consults or other items, even though they are actually, you know, for that patient's chronic condition. And the answer from the department is that, well, that's what this trial is for. That's how we'll learn how to what to watch out for, how to best, you know, keep practices accountable, and so there's a lot that we don't know, and that's what's expected to be revealed with this rollout. So yeah, if you have a look at even just the amounts that a patient would attract if they're just put on GP management plan and team care arrangement, that's, you know, $258 just for putting a brand new plan. Even if they're not that complex, like we would be doing, say even 1 or 2 reviews, so if we're doing it 6 months apart, that brings it up to 400 and over 400 or even 500. So again, if you have someone who's at that tier 1 level, it's not that there's not really that much more room to move in terms of, you know, that's sort of accounting for, we've done a plan, we've done a couple of reviews, and they haven't even come in yet once, so for anything else. So, and we're already at that kind of cap or yearly amount. So it'll be interesting to really see if practices are really benefiting or if they're better off or worse off. So it's a watch this space. Very interesting trial to see. The other area that's been of interest, particularly to me, has been this simplification or redesign of the practice incentive program. So from last year's budget, there was an item saying that a lot of the PIP incentives, such as the asthma cycle of care, diabetes cycle of care, the cervical, the underscreened women for cervical screening, those incentives were going to be redesigned and kind of simplified into one quality improvement incentive. So that was supposed to roll out this year, 2017. In May, which didn't happen. Again, it's been kind of caught up in a lot of rounds of consultation at different levels with different stakeholders, with PHNs, and we still don't actually have a lot of clarity about what it's going to look like. All we know is that it's a quality improvement is a focus, that there's going to be a big focus on data quality. The idea is that, you know, each practice will be able to define or decide what their focus will be. So for some it might be, you know, a diabetes focus, for some it might be asthma or COPD or whatever it is. But the main aim is going to be for practices to get some baseline data and then show improvements that they've done on that data. So obviously putting some kind of activity in place, quality improvement activity in place, and should demonstrate that you've managed to create get an improvement in your practice. Again, very gray at this stage. We don't really know how they're going to measure it, how they're going to fund it. We don't even know who that data is going to be provided to, if it's going to be provided directly to the department, or if they're going to use the PHNs as kind of like the middle person there to facilitate that. So again, a lot of these things are up in the air. For this reason, they've decided that the commencement of this is going to be from May 2018. So we still have, this tells me that then we still have another year to make sure that we use up that we do our cycles of care, all our asthma cycles of care and diabetes cycles of care, and that we optimize that the cervical underscreening incentive as well. So again, the idea is that once this redesign happens, all of those items that I mentioned are going to disappear, and this is the one that's going to be replacing them. There's been talks that, you know, clinics shouldn't really be disadvantaged, but last year this item came in under a cost savings for the government of $21 million. So it's kind of, and I may be wrong, but it's kind of difficult to see how, if it's going to save the government $21 million, how that translates to clinics not getting less money. Maybe I'm just skeptical. I don't know. That is partly what's going to be funding the healthcare homes, that savings from this. So the items, the PIP incentives that are not going to be affected are the teaching PIP, after hours, rural loading, e-health, the practice nurse incentive program, so PNIP, the Aboriginal or Indigenous health incentive, and the procedural general practitioner incentive. They will remain as they are, so those will not be affected. And the line item in this budget this year was that there's going to be funding of $2.5 million given over 4 years to ensure that the Indigenous health incentive and the procedural GP incentive are going to stay in their current form, because those two were still up in the air. Last year we weren't sure if they were going to be absorbed into that new quality improvement incentive, but now we know that they will, they're going to remain as they are. So that's good news for those of you looking after patients of Aboriginal and Torres Strait Islander background or Indigenous background. There is, this is an item that was in last year's budget as well. It's Enhanced Medicare Compliance Program. So the projection is that this is going to generate a savings of $103.8 million over 4 years. And it's essentially improving the MBS, or the Medicare Benefit Schedule compliance and debt recovery, which means, you know, this may translate into either more audits or better systems to stay on top of what they call unusual billing practices. To kind of highlight where there might be either, you know, clinics or providers who are a bit too aggressive in their billing, or who might not be actually meeting Medicare requirements for the items that they're claiming. So yes, it's an interesting thing to have, but it's recurring. We had this last year as well. Now, in terms of the My Health record, we have now confirmation that we're going to move to an opt-out approach. So an opt-out implementation at the moment, as we know, is largely an opt-in, except for the areas where we had a trial for the opt-out, which has led to obviously a very difficult subscribing or very difficult uptake of patients signing up. So the funding has been allocated as $374.2 million over 2 years to continue obviously all the efforts around the My Health record system, and to start gradually moving to that opt-out arrangement. implement. This is not likely to fully roll out, so this is probably going to be implemented in stages, and we'll be seeing it more likely around 2019, that it'll be sort of in full, in full bloom. There was a big project big consultancy or research project that looked at the trial, obviously, and those sites that had the opt-out arrangement, and that's what I'm referring to here as the Siggins-Miller report. I will provide the link to that report if you're particularly curious to read all the insights from that. But some of the key findings are that, obviously, as we would expect, using an opt-out approach resulted in greater participation in the My Health record. An interesting thing was that individuals, so this is patients, had actually relatively few concerns about confidentiality and security of the My Health record once the benefits were explained. That's something that's been kind of hammered a lot in the media, that, you know, oh, who's going to have access to our health information and all of that. But the reality is when obviously they ran focus groups with patients of all sorts of different backgrounds, and yeah, the concerns were actually not that many. Another thing is that people from CALD backgrounds, so culturally and linguistically diverse backgrounds, they greatly appreciated the My Health record system. So obviously having that one central place for storing that health information, and obviously having that better way for multiple providers to access their information was actually seen as greatly beneficial. So again, I will provide the link to the full report so that you can see it in more detail. But yeah, it's certainly, and obviously with clinics trying to meet their e-health PIP and the uploading shared health summaries, as we know, it's a lot easier if we already have patients coming in who have an active My Health record. So this move to an opt-out should help considerably, because it means that most people, unless they opt out, will actually have an active My Health record. So good news, I guess, but still a little while to come. This is a new item, Healthy Hearts Initiatives. This is funding of $15 million over 4 years. $10 million is going to go to the Heart Foundation to increase access to walking and other physical activity programs, and also to establish the Prime Minister's Walk for Life Challenge, which is to support up to 300,000 Australians to become new regular walkers. And the remaining $5 million is actually going to go to the RSCGP to develop education and training materials for GPs, obviously around, again, supporting healthy lifestyle with, you know, physical activity and better nutrition. So yeah, this will be an interesting thing. Not quite sure what the Heart Foundation resources will look like. Obviously, they currently run a lot of those walking groups, so this might either be going into creating, obviously, additional groups, or a campaign to recruit more people to those groups. But it'll be interesting to see what the RSCGP will put together. So yeah, I'll be knocking, we should all be knocking on their doors over the next 4 years to see what they've done with those $5 million, because they should come up with some great materials. In terms of the National Cancer Screening Register, we are eagerly expecting that this is going to be commencing from the 1st of December of 2017, so this year. And as we've all heard, and we may already be aware, there's going to be changes to the cervical screening program. And this is also going to be from the 1st of December. And the changes are that the 2-yearly pap smear for women, which at the moment is for 18 to 69 years of age, will change to a 5-yearly human papillomavirus test for women 25 through to 74 years of age. So the frequency will change from 2 to 5 years, the type of test will change, and the eligibility age bracket is changing as well. I will add a link with more information so that if you have any providers in your clinic who want to learn more, you can give them that link, or obviously if you're the one who wants to know more, you can go through that yourself as well. Now, No Jab, No Pay got a fair bit of support with multiple items, actually. And this budget. So one of them was improving awareness and uptake of immunizations through a $5.5 million campaign, which is going to be over 3 years. to specifically target areas of low vaccination rates. And the idea is to address obviously a lot of the myths and misconceptions around vaccination and explain the benefits of childhood vaccination. Benefits obviously both as an individual, but also more broadly to the community from a protection point of view. There's another measure of 14.1 million over 4 years to help improve coverage with free catch-up of childhood vaccinations for children and young adults between 10 years and 19 years who missed scheduled vaccinations, obviously at the time that they were due. This is also going to be available to newly arrived refugees and humanitarian entrants. So I was trying to see when this one would kick in from, because we already had a free catch-up in place from 2016, but this one is broadening it, and it's allocated as a spend for 2017-2018. So my guess at this stage is that it would be valid from 1st of July. Should be able to start doing this. But again, I would just double check with your state department as you're ordering your vaccines in your stock to just make sure that that's actually in place from then. Another supporting measure for the no jab, no pay is new compliance arrangements. So again, trying to motivate parents by or like counter motivate lack of vaccination. So there's actually now going to be a payment reduction of $28 per fortnight of the family tax benefit Part A for each children that does not meet the immunization requirements. So the hope is that obviously this is again another push or motivating factor hitting obviously the pocket to try and encourage parents to keep their children fully immunized. Just as a reminder, when it comes to the no jab, no pay policy, the idea with this is that children must either be fully immunized or have a valid exemption or be on a valid catch-up schedule. So if none of these apply, then unfortunately they'll be hit financially. So again, the idea is that in order for parents to continue receiving the childcare payments, this needs to be fulfilled. And now with this new measure, then this is what they're going to be needing to do in order to get the full family tax benefit Part A fortnightly payment without any deductions. And another interesting thing was the establishment of this Medicare Guarantee Fund. So essentially it's like a savings account. The idea is that we have set up this special account, which will be set up from July of this year to guarantee the commitment to the MBS, to having a Medicare benefits schedule, and to the pharmaceutical benefits scheme. Again, the idea is that the funds will be credited each year from both revenue raised from increases to the Medicare levy, but also from a portion of personal income tax. So again, it's like a piggy bank savings account to try and guarantee that we will still have Medicare and the PBS for generations to come. Now, in terms of practice administration, there weren't really that many items of great excitement, really. The main thing is this was a measure from last year. We have the immediate deductibility threshold of assets of $20,000 or less, which we had this introduced last year, but it's going to be extended for another 12 months. So if your practice has an annual turnover of less than $10 million, which kind of puts it into the small business category, then it means that you can immediately deduct assets costing less than $20,000. So this is the ideal for practice equipment. So obviously, as long as this is something that is going to be installed and ready for use by the 30th of June 2018. So again, have a look around the practice. If there's any big equipment that purchases that you know would fit this criteria, then this is the time to do it. And then from the 1st of July 2018, then it'll revert back to the threshold will revert back to $1,000. So obviously it's quite a benefit in the meantime if we can use this up. Obviously, I'm not a financial advisor. Anything to do with tax, you would have to consult your accountant for advice. But obviously, this is just highlighting some of the items that came through this year. Another item that might be of interest is more from a personal income tax. So there's going to be an increase in the Medicare levy that we all pay, and this is to help fund the National Disability Insurance Scheme, the NDIS. So what will be happening is the Medicare levy is going to be increasing from 2.0 to 2.5% of taxable income from 1st of July 2019, again to fund the NDIS. Obviously, the low-income taxpayers will continue to be exempted, and by low income, there's the thresholds for singles, which will be increased to $21,000, and for families to $36,000 plus obviously $3,000 plus for each dependent child or student. Again, I will include a link to the details of this if you want to see how this applies to pensioners and things like that. But again, this is something that's likely going to affect this increase is going to affect most people in the practice, most definitely staff members in our practices.